All right. So this next video, this next lecture, is going to be on carpal tunnel syndrome. So we're going to kind of go ahead, do what we've been doing as with some previous conditions, but go over specifically carpal tunnel syndrome or CTS. Um, so as you might see in the pattern of my layouts, first I'm going to tell you what it is, how does it happen, explain the anatomy and physiology aspect of it, how is that contributing to or solidifying the symptoms that the patients are experiencing. In this one specifically, we're going to talk about provocative testing. You'll see why that's important in a bit, what a evaluation might look like, and then lastly, some treatment. Again, just to state off the bat, this isn't necessarily something that you would follow along step by step for a treatment of an individual with carpal tunnel syndrome. It's more so giving you that fundamental knowledge and foundational experience with the condition to kind of get your head spinning and thinking about what you might do with a patient with carpal tunnel syndrome, what you might be thinking, and how to like troubleshoot and problem solve with this condition particularly. It's sort of that Kickstarter there. So let's get started. So CTS, a condition specifically caused by the compression of the median nerve as it passes through the carpal tunnel. So on that wrist side, and that compression of the nerve will oftentimes lead to the patient feeling numbness and tingling and weakness in the hand. We'll talk about specifically where in a bit. So we'll talk about how this specifically the tissue surrounding the flexor tendons in the wrist, they will swell up and thicken, which decreases the space available within the carpal tunnel. So, for example, there's 9 tendons that are flowing right through the carpal tunnel and the median nerve as well. So when you have decreased amount of space in an already tiny little spot, the pressure increases, and this can result from repetitive hand use, wrist positioning, or traumatic injury. But there's different ways that this can kind of spark or aggravate those tendons in the nerve. Let's talk about the anatomy and physiology. So here's just sort of a introductory chart of the 9 flexor tendons specifically that are traveling through the carpal tunnel. The table itself will kind of go over the origin, the insertion, and the action of each muscle. So feel free to pause this and give it a read. I'm not going to read it out each individual one by one, but just kind of get an idea of that it's these flexor tendons that are kind of traveling into through the carpal tunnel. So keep that in mind when you start thinking and problem solving about what actions might be affected when you have compression of the median nerve and swelling within that carpal tunnel, and these tendons being perhaps inflamed and bothered, aggravated. Oh, and one little note about this is I want to note that these flexor muscles also have some assistance in wrist flexion, and they're innervated by the median nerve, an exception of the medial half of the FDP, so the flexor digitorum profundus. That one's innervated by the ulnar nerve. So that'll make a little bit more sense in terms of like when we start talking about sensory distributions. I'll have some images in a couple slides more about the median and the ulnar nerve, and it'll kind of give you an idea of where the symptomology might be occurring, and it can help you with your problem solving, especially when it comes to an eval. So let's look at the canal specifically. So in this image on the left, brought to you by Johns Hopkins, you can see that transverse carpal ligament. You'll often see this in charts being abbreviated to TCL, but that ligament that's going longitudinally, or transversely, I suppose, um, is kind of forming that roof of the carpal tunnel. And then, so if you imagine that being the roof or like the top part of the carpal canal or the carpal tunnel, the median nerve and the 9 flexor tendons are traveling right underneath it. And so that base behind it, so below the 9 tendons and the median nerve, you have the carpal bones. And so that kind of forms that carpal tunnel or carpal canal. You'll see it written both ways in literature, but that tiny little space where it's kind of like a highway. These are just running right through. And when you have inflammation or it's being aggravated, the inflammation of these tendons can kind of squish that nerve already with that limited space that they have because of the TCL and the carpal bones. but it's sort of difficult to show how an actual compression necessarily looks like, but I think that this image specifically does a really good job of just kind of showing you what that tunnel looks like. I know on the right they just kind of showed the redness showing like aggravation and pain, inflammation perhaps. Um, but another thing to keep in mind, so when patients go under carpal tunnel release surgery, so CTR, essentially the hand surgeons are working with this TCL in most cases to sort of expand it and give it more breathing room, more space for these tendons in the median nerve to travel so it's not as compressed or being pushed upon. Um, but you'll read a lot more about that in some notes that you'll get when you get referrals with CTR patients. But I'll also try to add a piece of literature. I remember reading one specifically when I was in my level two, but I'll try to find it and link it into the Moodle. Pretty interesting about like standard approach for CTR in most patients. Just kind of common practice. All right. So this view kind of gives you a better view of the tendons. So kind of imagine that the hand is being like kind of like cut and you're looking into it. So these blue little markers here are the flexor tendons that I was talking about, the nine of them, the median nerve being at top. So you can kind of see, it kind of gives you an idea of that tiny little space or tunnel that they're traveling through, trapped between the TCL and the carpal bones. Um, but when you're looking back at like the origin, insertion, and action chart, you can produce various finger flexion movements. So these muscle tendons are actively gliding through this carpal tunnel when we're performing those actions. So kind of think of it as kind of like a floss or just kind of like a glide. So when we're performing these finger flexion activities, just keep in mind of where these tendons are inserting, where they are originating, and so performing certain movements. So in this case, finger like flexion, you'll see that the tendons are trying to imagine that those tendons are traveling in and out, kind of gliding through that carpal canal. And that's something actually that we want to promote because if they kind of are getting more fixated and stuck, it just kind of increases the pressure there. So when that tunnel becomes more narrow than it's supposed to be, the tendon excursion or the tendon movement with the increased pressure within the tunnel can cause the individual a lot of pain and a lot of discomfort and drastically limit functional ability, especially individuals who are working perhaps a lot with their hands and their wrists. It's just not fun for them, not fun at all, especially with the sensations and the pain that they feel. But speaking about sensations, here's that little slide or imagery that I was talking about earlier. You can see that the median nerve itself, so it provides sensation to the thumbs, the second digit, the third digit, and half of the fourth. And then you can see on the other side in the image, it kind of has a bit of the dorsal aspect of those fingers as well. Um, I think the image is a really good job. It helped me during my level two field work in sense of kind of understanding if patients are feeling sensation deficits or report tingling on perhaps the index finger and they came in from a carpal tunnel syndrome referral. It can kind of put two and two together about kind of validating their pain essentially. But if you start noticing that the individual is feeling sensation deficits on an ulnar nerve distribution site, so let's say, for example, the pinky, it can kind of help you with your clinical reasoning, especially during an evaluation. But this is kind of important to understand when it comes to diagnosing accurately, forming your treatment plan, ensuring that you have the correct sensory testings for the specific nerves in the hand. So like the Siemens-Weinstein monofilaments or using two-point discriminations, they can be applied directly along using these sensory charts with the proper like patterns. So essentially, you want if you're going to be testing the median nerve for carpal tunnel syndrome, you want to be sure that you genuinely are. So if you're doing two-point discrimination on the pinky, you're not really testing the median nerve. Instead, you're testing the ulnar nerve. But this will be really good foundational knowledge for you to understand so that you know what you're testing and what might be the problem when it comes to an evaluation specifically. The median nerve, however, you can see on the image on the right, you can follow the nerve up the arm and note that it's a very long pathway connecting into the brachial plexus. I won't go too in depth into that one, as we've spoken a bit about it in our neuroanatomy module. But take this into consideration because it's important to know that while the median nerve can become compressed at the carpal tunnel, it can also be compressed in other areas along this pathway specifically as well. So I kind of listed some. But some of the common sites of compression can be at the pronator teres, the ligament of Struthers, which is pretty rare, but I find it interesting as a rabbit hole that I found. But also like the anterior interosseous branch and even like the scalenes. I'll talk about some of these in a bit. But if proximal compression exists, treating only at the wrist level will not fully resolve the patient's symptoms. So if they're having like similar symptoms to carpal tunnel syndrome, but the compression's happening at a more proximal site in the upper extremity, approaching it as if it were a carpal tunnel syndrome and treating it distally will not completely get rid of those symptoms. They might feel that they're getting a little bit better, but it's not going to necessarily cure it by any means. So we'll talk about some of those potential proximal sites here. So here on the image on the left, you can see just an isolated image of the pronator teres. So you have both heads, so both the humeral head and the ulnar head. And the typically a bit of another rabbit hole that I won't go into, but there's variations in the path in which the median nerve travels in this specific area for some people. But for the most common anatomy in most individuals, found that the median nerve travels between the two heads of the pronator teres, so kind of like sandwiched in between. But it can also be a form or a site of compression here at the elbow. Um, and so specifically when we're talking about the compression at the pronator teres, so we'll focus down below, down here. Um, it gets compressed between the ulnar and humeral head. People tend to kind of refer to it as like pronator, I believe it's like pronator syndrome. Don't quote me on that one, but essentially just like a common term of proximal compression that can cause similar symptoms to a patient. One on the top is the ligament of Struthers. This is one I said it was interesting because it's not present in everyone. So in fact, it's a variation that's only seen with people who have on top another variation on their distal humerus called the supracondylar process near the medial epicondyle. Pretty uncommon, but it's, I believe, present in 2 to 3% of the population. So essentially, there's this like extra bony prominence on that humerus that causes the ligament of Struthers to be present, and that little site of compression right here on that tiny ligament can be a site of proximal compression. While uncommon, this can be a compression site, and as it's a rare ligament, it's not something you necessarily want to count out. But it's just kind of an interesting rabbit hole and how anatomy can vary between person to person. Um, but yeah, let's look into the next one. So we have the anterior interosseous syndrome. So AIN, as you'll usually see it because of the anterior interosseous nerve. This is also a median nerve entrapment. However, it's specifically the motor branch of the median nerve. So you can see like that branch off from it, kind of like near this circle right here. So it points down, median nerve right here. Here you have this branch off kind of waning out here towards like the midline of the forearm. But with this syndrome, there are no sensory symptoms usually. So because it's a motor branch, so no numbness or tingling that is often seen with typical carpal tunnel syndrome. So compression of the median nerve through the carpal canal. But patients will often report non-specific pain in their proximal forearm and the pain can be exacerbated, increased with activity and like overuse. So in this syndrome specifically, the flexor palmaris longus or the FPL to the thumb and then also the FDP to the index and the middle fingers um, are affected. So this results in like a weakened distal IP joint. And a way to check this is kind of asking your patient to form the OK sign. So with those weakened IP joints, you can see that it kind of appears that it's kind of like collapsed. They cannot make that perfect O, for example. So on that DIP, There's just like a lack of flexion there. But this specifically is called Ballantyne sign. Um, so it's just kind of like a name given to this specific like phenomenon. But the hand on the left and this image on the right. So sorry, the image on the right. So look at the hand on the left, but it's demonstrating a positive Ballantine sign, and you can really tell because of the index finger's DIP joint is not producing the flexion needed to create that circle with the thumb, as like the hand on the right is doing. Um, so in this instance, I think it's important to note that with AIN and pronator syndrome, these tests will often present with a negative Tinel sign, and I'll talk about that here in a second. But knowing this can kind of help you think about proximal compression of the median nerve if the patient has symptoms similar to CTS. But just kind of hold on to that thought that essentially patients with AIN and pronator syndrome tests like the Tinel sign and other common carpal tunnel syndrome tests will present negative, even though they're experiencing other similar symptoms. So let's get into the provocative testing where I'll talk about the Tinel sign and like failings. So first, the failings test. Um, you'll essentially ask your patients to place their back sides of their hands together and then hold them near at chest height for about a minute. The act of flexing the wrist increases the pressure within the carpal tunnel, thus compressing the median nerve. So if the nerve is already compromised, this will likely provoke symptoms, confirming nerve irritation and compression at this site. Tinel site is the tapping um, on just proximal to the wrist crease, and it'll often produce tingling or people have reported like electric shocks feelings along the median nerve distribution on the thumb, index finger, middle finger, and the lateral half of the ring finger. The nerves are, in this instance, hyperexcitable when irritated or when they're regenerating. So these light taps over the area can trigger these sensory signals specifically. It's pretty interesting, but you actually don't have to exert too much pressure. When I have done it, I've used two fingers just tapping over the sign, and they've described it as like those little lightning bolts, like in the image shows, kind of going through that median nerve distribution. Two other ones, the carpal compression test or Durkin's. So you're essentially placing direct pressure over the localized area and kind of mimicking the effect of carpal tunnel compression, increasing the pressure within the carpal tunnel. If the nerve is already irritated or compressed, then the increased pressure that is applied can trigger nerve irritability. This is a very focused and direct test as you're applying pressure. You don't have to put too much pressure onto the individual. You obviously don't want to cause any bruising, but you'll find that if the patient, if these nerves are already irritable, the patient's going to be very uncomfortable pretty quick. The next one will be sensibility testing. So you can use things like the Siemens Weinstein monofilament test or the two-point discrimination can kind of, as I mentioned before earlier, can help confirm or identify any sensory deficits caused by potential CTS. And in this case, you would again test along the median nerve's sensory distribution patterns. You can use that other slide as kind of like a follow along or a map, or I found it helpful to draw it out myself and color it myself. But it's important to note that any sensory deficits in any part of the hand, even if it's not along the median nerve distribution, will help you understand their symptoms and evaluation. And it's very important to document all of that. Next, let's move on to a bit of the evaluation aspect. So kind of giving all that information. You'll obviously, first and foremost, you will want to talk with your patient, listen to them. It can be really easy to read referral or listen to initial complaints for a new patient and kind of get hung up on a specific diagnosis. You can kind of find yourself sometimes clinging on to them, but it's really important to just listen to them, kind of gain that important subjective information from them. So, where are they experiencing the pain? What is triggering the pain? What alleviates the pain? And how long has this been going on? So asking them if the symptoms are occurring during work or during at home or when they're sleeping, which is very common with CTS. But this will help you gain that subjective information that will ultimately help guide your evaluation. and guide which provocative testings that you will be performing. So keep that with a grain of salt as I go through this evaluation checklist, because it's essentially kind of like an audible, really. You you treat what you see and you perform the test based on what you see and what you hear. So don't follow like a cookie cutter format when it comes to this. But it can be really useful to gain all of the subjective information from them to kind of gain more insight on like potential triggers. Or if perhaps they're at work, they're performing excessive or extended amounts of time gripping, ergonomic factors that might come into a play. Um, so next, it's useful to use provocative testing. This will help with your clinical reasoning and assess anatomically what might be causing these symptoms for the patient. It can give you an idea of what nerve or nerves may be irritated and an idea of where the compression site may be. So as mentioned in previous slides, some of the most common provocative tests that can be useful can be the phalanx, the Tinel's, carpal compression, and that's testing directly at the carpal tunnel. But then you can also perform a upper extremity tension screening. So essentially you test the three major nerves that are within the upper extremity, the median nerve, the ulnar nerve, the radial nerve as well, and have them perform different types of nerve glides and assess which nerves might be irritated or feeling tight perhaps. But performing these specifically bilaterally will be useful for them. So essentially when I have performed nerve glides with patients in the past, explaining the feeling of when a nerve might be irritated is a little difficult. It feels like a tug, so it's important to kind of find a way and get your spiel of how to describe what an irritated nerve might feel like when performing these nerve glides. But using both right and left arms can be a useful way for them to kind of get that biofeedback independently for themselves. But typically you'll feel that strong pulling or that tugging when performing these nerve glides. And I'll attach another separate document within this module, common nerve glides for each three of these nerves that I've used in the clinic before. And then I believe I have another video that's useful um, from Virtual Hand Care, a YouTube account that's super useful. Um, Moving on, this qualitative information will also be useful here to understand the symptoms that are impacting the individual's overall range of motion and strength. So you'll want to get that goniometry out again. You'll want to assess grip and pinch strength. You'll notice that oftentimes with people with positive carpal tunnel syndrome symptoms, the grip strength test is going to be painful. And so you'll oftentimes see that it's weakened, but you'll also want to assess both right and left for comparison when it comes to both strength and range of motion. So ergonomics, huge role in carpal tunnel syndrome. I attached a document for sure from the Journal of Hand Therapy on how the workplace can have an effect on carpal tunnel syndrome symptoms. I think it's very useful. But essentially, you can often assess the individual's ergonomics when they're in the therapy clinic, noting things like how are they sitting in the chair, what is their approach to holding objects. You can also ask questions about their ergonomic positioning at home when it comes to like sitting at the desk or perhaps when they're taking their breaks. So like getting the idea of what they do on a day-to-day basis, what their posture is like, is their wrist resting onto something? An individual I had in the therapy clinic, he was having positive carpal tunnel syndrome signs and symptoms. And when he's a truck driver and he was resting his affected hand on his like gear shifter from like park reverse neutral drive, essentially already performing that carpal compression test on himself, applying pressure to the carpal tunnel. And so that consistent and prolonged compression there specifically was just kind of causing these unwanted symptoms. Um, but after that, you'll also want to know that you're taking a big part of this is educating. So you'll want to promote neutral wrist positioning, reduce repetitive movements if possible, reduce forceful or prolonged gripping, and improve the posture and overall body mechanics from a day-to-day basis. So that can look like taking that 90-90-90 rule when it comes to sitting. So when you're sitting and making sure your feet are flat on the ground, your knees are making that 90 degrees, your hips at 90 degrees. Your head's not necessarily looking all the way down at your computer. Try to get it to eye level. Um, Ergonomics in terms of lifting with your legs instead of your back when it comes to moving heavy weights consistently at work or at home. But let's kind of like dive into like how these specific activities or motions can impact the symptoms really, really quickly. So repetitive motions like using a hammer repetitively or working at a construction site can cause cumulative trauma to the wrist, kind of increases inflammation within the carpal tunnel. Prolonged wrist flexion and or extension can increase pressure within the carpal tunnel, which worsens nerve compression. This can be seen with individuals who are using a computer frequently at work, when you got your hands in that typing position for a prolonged period of time. If you don't have a rest that might help you neutral, like put your wrists in neutral. Frequent gripping of tools or objects can increase the strain on the flexor tendons. As I mentioned on really early on in the slides, the finger flexion is the movement produced by those flexor tendons that are traveling through the carpal tunnel. So prolonged grip or a pinch, such as like holding tools or equipment, can increase the pressure within the carpal canal. And then also a lack of task variation or access to breaks can prevent muscle tissue from truly fully recovering and getting rest, which can lead to overuse and nerve irritation. So while this isn't necessarily a compiled list, it's just sort of some to list out. But I encourage you to do more reading as there's plenty of great literature on the role of ergonomics in carpal tunnel syndrome and specific activities that aggravate it. Lastly, these last two sections really go one with another, but educating and also creating the home exercise program. You want to discuss what the nerve entrapments are, explain how the irritation might kind of be triggered and the symptoms be triggered by things that they're doing in their daily lives or in work lives based on the eval that you performed. So you'll want to educate them on the proper body mechanics, conservative treatments that are beneficial to reduce symptoms experienced. You also want to walk them through their HEP at home. Um, I'll have some like list of exercises that are potentially useful and common. Essentially, you want to get that nerve gliding, those tendons gliding. You want to avoid causing more pressure into the carpal tunnel. So you'll want to perform activities with your wrist in neutral, for example, but you'll want to guide them through these exercises that will help alleviate pain and help push them and motivate them to make these lifestyle changes that will help them in the long run as well. Because you'll find that sometimes you'll get patients who might not be doing their HEP, and sometimes they'll be very honest with you. Sometimes they'll try to beat around the bush, but you can usually see from most literature that carpal tunnel syndrome symptoms typically decrease after like 6 weeks when performing these um, with therapy. Generally, with therapy, it typically helps and kind of not necessarily goes away, but it's not as bad as it used to be necessarily. These lifestyle changes, ergonomics, and these exercises can really go a long way. But you will see sometimes that in some cases people don't have their symptoms go away, that they're still feeling the pain. They can't avoid necessarily um, avoid these actions that are causing that nerve to feel compressed and that tunnel to be uh, tight and experiencing with increased pressure. But there's other little things that you can do as well, like essentially adding grips to items that you have to grasp, reducing the amount of flexion required in the fingers. So kind of adding a foam pad to handles and stuff can be like tricky little like not tricky, but creative ways to tackle the same problem necessarily. But this is definitely a time where you can sort of challenge your own like clinical perspective and your own clinical creativity as well when it comes to your patient and their specific job or occupations. So next, briefly, just very briefly, treatment. This one's pretty bare. I do really want to highly encourage you to kind of think about it on your own in terms of what you can do within a therapy setting, given your resources, but I'll also attach some exercises and common activities that people might do in treatment for carpal tunnel syndrome. But the goal for treatment with a patient who has CTS will be to overall promote tendon gliding through the carpal tunnel and decreasing the inflammation and pressure on the median nerve. So the elimination of the symptoms is the goal, and this can really just be achieved through thoughtful clinical considerations and activities that don't increase the pressure within the carpal tunnel. Ergonomics play a big role. Again, you'll assess and make ergonomic recommendations that directly apply to their work and home life. This can be with like sitting, external pressures, body mechanics, looking into their home at work, etc. Those tendon gliding exercises, getting that to floss through and move the way that it's supposed to do, performing the activities with wrist and neutral help a lot. The nerve glidings as well. And then lastly, I will touch on this very briefly, but night splinting. So most patients feel their symptoms while they're sleeping at night. This can be from sleeping in awkward positions or having their hand directly under the pillow with their head on top of it as well can kind of cause increased pressure onto that carpal canal. But you can essentially use prefabricated and or custom splints, typically fitted at like zero at neutral or up to like 15 degrees of extension in the wrist, sort of kind of opening up that carpal tunnel can be very useful. We wouldn't necessarily recommend patients to be wearing it 24/7 necessarily, but if most of the symptoms are being experienced at night, this is a great time to be wearing one, and it can help them gain more sleep at night too. But that's all I'll note and plug in there. I'll have some extra additional resources within the module. But again, thanks for listening, and I hope that this was helpful.